Warm welcome to you from Geneva, Switzerland. You know me, and some of you know each other. We've just gone through the twinning or the IA2030 triplets, so I hope that many of you have been successful in connecting with your twins. Today, Tuesday and Thursday, we offer these experience sharing sessions, which provide a unique opportunity really to check in. We are going to ask you to present your action plan, to tell us whether or not you have submitted it, and whatever the case, to present it. And then we're going to turn to the rest of the members of the movement who are in the room to share their experience in relation to the action plan that has been presented. So at the 30-minute mark, we will mark a pause and ask if the group wishes to extend the session. Today, exceptionally, we have a hard stop at the 40-minute mark. So we will quickly mark the symbolic pause. It's a kind of ritual to emphasize that if you stay, it is because you want to. You chose to attend this session. You chose, and that is, you opted in, and that is important. So the first thing we will need is a volunteer. So if you can go to the reaction, I think it's the reaction panel. Now I know with the Anglophones, I think this may be a technical problem. The reminders go out late, have been sent out too late. And so we get a stream of people flowing in after a person has shared their story. And this is very unfortunate, because then it is difficult to share relevant experience if you have not heard the first story or the action plan that has been shared. So I am going to ask for a volunteer. We'll make do with this technical issue. And I do need someone to raise your hand, to share. That is the point of the experience sharing session, or else we can make it a very short experience sharing session if no one has experience to share. Rajesh Gupta, thank you for being the first to raise your hand. I'm asking you to unmute. And yes, Rajesh, a warm welcome to you.
Thank you, sir.
So please introduce yourself, tell us who you are, what you do, where you work, and then tell us your priority challenge, objective, and then we'll go into the actions. But let's first hear who you are, what you do, and what your challenge is.
So myself, I'm Dr. Rajesh Gupta. So I am working in India as surveillance medical officer with NPSP WHO. So the main area we are looking after is immunization, routine immunization. And my area, I'm working in one of the state, Rajasthan state of India. In Rajasthan state, I am looking after 3 districts, that is Kota, Bara and Budi. And Kota is basically a urbanized district. So definitely we find challenges regarding the migration from the rural areas, from other districts and from other state to the Kota urban for various kind of work like constructions and other activities. So the main challenge to catch them for routine vaccination, as they are not the part of the routine system which is existing. So we don't have the details. So this is the migration is, very frequent and very continuous. So, and when we go to, these places where they are staying with temporary houses in a nomadic population, so we don't find them at home. They leave early and they came late in the evening. So we don't find physically the people, but we come to know, some say 15 families, 20 families are staying at such a place as a temporary nomadic population, right? So it was a challenge for us, how to vaccinate their children. So we were looking after various options, and we are planning, to contact, the people who are giving them the basic employment. We try to connect them, but nothing was working actually. And somehow we got an idea, there is a holiday. So in India, there is a Hindu calendar as well. And Hindu calendar, basically, it is based on moon, lunar month. So there are 28 days. And in 28 days, there is a, system of one holiday, which is on on Amavasya holiday, it is called as when there is no moon. So one is, the full moon, and one is there is no moon day. So that is called as Amavasya holiday in India for Hindu calendar. So that day is is only the one holiday every month. So somehow we got an idea, why don't we vaccinate the children on this particular day? We will be finding all the families at home on this particular day. So we planned how to cover all such areas in Kota urban and Kota urban. We have to list out all these such areas, and we have to deploy manpower to cover all such area in single day. It was only one opportunity we were getting in 1 month. So I can go through my slides also, if you allow me, sir. Can I share my slide also?
Yes, please.
Thank you. Please allow me to share my screen, please. Okay. Thank you, sir. So is my screen visible, sir?
Yes, it is.
Thank you, sir. So we gave it a name, Amavasya, the holiday which is I'm talking about. Amavasya Titakaran is vaccination program, ATP, in Kota urban. It was mainly focused on the urbanized part of the Kota district. So it was preferably the urban based activity, and it is the only holiday for all the laborers once in a month, right? And children remain unvaccinated in routine immunization and sometimes in Mission Indradhanush also. There is a mission mode immunization program is also run by the government of India. Due to unavailability, we are planning session, but we are not finding the beneficiary, because the dates are declared by the government of India. On these particular dates, they are not available on that particular sites, because they are leaving early in the morning and they are returning late in the evening. And there was poor acceptance also sometimes because of the loss of the daily wages. If we are finding them also, they are not allowing us to vaccinate because of the fever to the children. So there was a fear of minor AFI, adverse event following immunization also. And usually they are from other districts and other states, hence don't aware of the local health delivery system also, where to go for the vaccination. Sometimes they want, their child is due, but they are not aware where is they can go and visit and get their children vaccinated. And there is a lack of manpower in urban area. There is always a issue of manpower in compared to the rural area. In urban area, we are finding challenges regarding the manpower. So what we did, we planned activities in this ATP, Amavasya Titakaran program, vaccination program, orientation of all concerned planning units where we are having such sites, medical officer in charge, and there is a public health managers also. 2 weeks before the activity, we identified the typical areas and sites for this activity using the polio microplans and HRA list. In polio, we identify all the high risk areas, and we enlist all the polio high risk area, and definitely there we ensure that all the children are vaccinated during polio rounds. So we used that particular list for making our plan for ATP. We do field validation and list updation of such areas for proposed Amavasya activity. We used the available manpower to validate these areas and update the list for these areas. We deployed manpower from the rural areas, that is block program managers, block health supervisors, public health supervisors, for preparation and management of this activity. We deploy 140 ANMs from the rural areas for this activity, as the sites are more and we have to cover on all the sites in 1 day every month. So we pool the ANMs from the rural areas. We pool some vehicles from the field also from other programs, because we don't have additional fund for this activity. So we use manpower, the vehicles from the available resources. We deploy some district monitors for monitoring of this activity also. We divide the Kota urban in various zones, and we allotted the areas also. Vaccine and logistics. So definitely that we took the loop, state in the loop, and they extended the full cooperation to ensure that all vaccines will be available for this activity. State approved some funds for I mean the people who are deployed to the urban areas, that they can be given for 1 day for vaccination. All the vaccine were ensured. Logistic, including like tally sheets, we developed some tally sheets, some medicines, essential medicines, ORS, zinc ORS we ensured, in zinc tablet also, and ensured in advance via deployed manpower. We prepared the micro plan in format 1.1 and 1.2. I will be sharing the formats also. We identified sites, 96 sites for this activity, and we deployed 114 ANMs for rural areas. We pooled 9 vehicles from, I mean, the rural areas, and we developed, I mean, for this planning, 12 managerial staff like block program manager, block health supervisor, and the local ANM of the urban area was worked as a supervisor because she knows the area. So if 10 ANMs deployed to one PSC CSC, so she will work as a team leader. She will be the supervisor. And we deployed 5 monitors from the district. So in all, when the activity was conducted, we vaccinated 668 children in identified, we can see, I mean, the 96 sites. We vaccinate 668 children from which are typically migratory. There, I mean, I can say that they all were left out children. They were, I mean, either no vaccination or they are having, I mean, inadequate vaccination, partially vaccinated. 48 new ANC were also registered, which are pregnant but not registered at any place. 55 children given DPT1. Here in India, up to 1 year, we are giving Penta 1, Penta 2, Penta 3. But we find 55 children which are totally unvaccinated up to 1 year. So after 1 year, we are giving them DPT, I mean, DPT calendar. I mean, as per the DPT1, DPT1, DPT2, DPT3, we are not giving after 1 year the Penta 1, Penta 2, Penta 3. So they will follow this particular pattern, DPT1, 2, 3. 46 children given BCG, because they were either delivered at home or some other places where BCG was also not given, and they were vaccinated for the first time in their life. So out of 668, 101 children were vaccinated for the first time in their life, that is around 15%. And for 117 children, they were completed their vaccination, and 209 children were having full immunization, I mean completed immunization. If we give the measles at, I mean, so this is considered as full immunization. If the 1.5 year booster is given, that is considered as a full immunization. So this is how we, I mean, that was the outcome of this activity. So is this activity was useful? So definitely the answer is yes, because the children which were vaccinated, they were not touched by any program, any system, because they were not available during routine immunization, and other sometimes we are giving some immunization through mission mode. So children available at home with parents is a key factor for vaccination during Amavasya, which is not so in other RI and Mission Indradhanush. 1 day activity with mobilization of ANM and vehicle from rural area yield more outcome and did not affect any services in their respective area also, that we also ensured. And manpower deployed from various worked very enthusiastically and actively, as it is a single day activity. If we made plans of activity for 7 days, so I mean the worker don't take any interest. So it was a single day activity, so everyone participated very enthusiastically. Focused activity will full utilization of all available resources and manpower from different capacities. So that was the main idea, that we don't disturb anything, and with the available resources we completed this activity. So challenges was acceptance by the community is an issue, as there is a lack of faith, as I mean there is no relation between the service provider and caregiver, right? So that was lacking. So there was some acceptance issues, as they are from other areas, other state, other districts, and there is no pre-existing rapport with them. So definitely, I mean, later on, I mean, when we conducted the additional round, so I mean, we developed a rapport with these people and acceptance was better. Fear of minor AI5 is a cause of concern. So definitely they were saying if the child develops some fever, where will we go? So definitely we shared the number with them. I mean, you can call us whenever you have some difficulties after the vaccination. RI card is not available. That was very big challenge. I mean, we are not aware, I mean, how many doses has child has received. So that was one of the challenge. So somehow we, interview the beneficiary. How many times the children has been, how many shots are given at thighs, how many shots are given on arms, forearms. So definitely that kind of interview helped us, to overcome how many vaccination has been given to the child. Lack of proper place of vaccination, as I told you, they are staying in open lands as temporary nomads in tent, making temporary tents. So that was because, where to vaccinate them. So, the idea of canopy came into action, that we can have some canopies and there we can put it at these temporary places and vaccinate their children. Mobilizers are deployed from other areas, and follow up before and after vaccination was difficult, but because they are not part of any of the area. So they were not, nobody was having the responsibility for mobilization and any assistance after the vaccination. So way forward was IEC activity will be added to further strengthen this activity, use of loudspeaker and pamphlets, visibility of session to be improved. As I shared, developing some canopies and the banners and tents. Mobilizer to inform the community in advance by mobile and other resources, and follow up after vaccination. Better documentation of vaccination, developing register so they can be tracked on follow up vaccination sessions. Additional activities like identification and referral of the malnourished children was also, as their children are, not adequately feeded. So definitely it was also added. We can, there is another program, the treatment of malnourishment children. So we can identify the malnourishment children as per the guideline MUAC tape, and definitely they can be referred to the medical colleges for the treatment. Deworming was also added. Vitamin A supplementation was also added. These are the programs which are, these are the beneficiary, but they are not getting the advantage because they are not the part of the system, as they are staying as a temporary settlements in the urban areas. These are the formats which we designed, for this activity. The team 1, 2, 3 site they will be covering, who will be the ANM and GNM who will be vaccinating, location, category of the area, the type of community which is there, approximate number of the beneficiary to provide the vaccination, type of timing of the session site, and name of the mobilizer who will mobilize, and their phone number and designation of the mobile number. And this is the vaccine delivery chart, who will deliver the vaccine and who will be the mobilizer, who will alternate vaccine delivery system, it is called as. This is that the reporting, how many this is the tally sheet which will be used by the ANM, the name of the beneficiary, father's name, permanent address, and which is the vaccine given to this particular beneficiary. And this will be compiled later. This is compiled later, how many children are actually benefited and what are the different doses, different antigen they were given. So this is how we develop this activity to vaccinate these children, which is totally left out as far as the routine immunization is concerned. And we developed this Amavasya Titakaran program, and it was very useful to reach these children, because they are totally left out. And we don't know when they are going to get their vaccination. They might be going back to their villages sometimes, and they will there are chances they may get the vaccine, they may not get the vaccine. So this is one experience from my side, and if anything additional I can share with you, I am open for this. Thank you very much from my side.
Thank you very much, Rajesh Gupta. Before we go to François Gasse, I see there are a number of questions, and then you can raise your hand, but I recommend, because we are ending, we have a hard stop for today's session at the 40-minute mark, that you type your questions or comments in the chat, as Thuo Samson has done. So Thuo Samson has a question. The number of children accessing the first dose is quite high, meaning high zero-dose children. What would be, in your view, Rajesh Gupta, the best sustainable strategy to reduce these high numbers and ensure regular access to vaccines, given that we're talking about a mobile population, if I understand correctly?
So definitely, as I told you, I mean, these migratory population, they are staying at a place where they are not the part of the system, and system is not having any information that any such child is residing in their area, which is not immunized or which is under immunized, right? So definitely, we are using the opportunity of polio campaigns to enlist these areas, and we are doing the surveys by our available manpower. There is always a manpower crunch in the urban areas. So we are enlisting these areas, and we are trying to attach these areas with our routine immunization activity. I tell you, this is, I mean, additional activity to the routine immunization. So attaching these areas with the routine immunization. So 6 monthly, if we can do a survey and update our list where these migratory population are residing, so definitely we can give our regular services, and we can develop a rapport. I mean, that is very important, developing a rapport with this community. So this is how we can reduce the number of the children which are totally unimmunized, and the proper listing of the areas and giving the regular services. So and at this opportunity, Amavasya is one opportunity. Once we sensitize the parents and tell them the importance of the vaccination, definitely they can one day they can take leave from their work, and they can get their children vaccinated also. I mean, it is not that thing ki it is something, the gap is on the from the both side. They are also not aware, and we are also not able to convince them, I mean, how important is the vaccination for their children. We tell them sometimes ki if your child got sick, I mean, because of these 11 diseases, I mean, 11 antigen we are giving, any one of them, if your child is going to get, so you will daily wages you will be losing. In addition, you will be losing more money in the treatment of these children. So they get by communication things, right?
Thank you, Rajesh Gupta. We have a question from Melissa Teferi, who wants to know, what is the root cause? Says, if I'm clear, you're planning the children who are not vaccinated, and wondering about what you have identified as the root cause. And you can tell us, Rajesh, when did you join the movement, and did you participate in the situation analysis exercise, before answering that question about root cause? And then we'll go to Ndaeyo Iwot from Nigeria for comments or questions. We'll see. And then probably to François. And unfortunately, we have a hard stop today at the 40-minute mark. So first, when did you join the movement? Did you do the situation analysis? And whatever your answers to those two questions are, what did you find to be the root cause of the situation you're describing?
So definitely, I'm working here in this area on behalf of NPSP WHO. So I'm associated from the starting of this whole activity. So with the district immunization officer, I mean, when we go to the field, we find these challenges, I mean, during routine immunization. And I told you the mission Indradhanush, which is run by the government of India, we find that we have deployed the team, but they could not vaccinate the children because they were not available actually. So we interacted with the people when they can be available actually. So they said ki only one holiday is there in every month, right, for laborers. So I interacted, I mean, from the start of this, and we analyzed the data. I mean, the session we are planning, but we are not getting the children which is actually expected. And so we find this opportunity while moving in the field, while monitoring in the field with district immunization officer. And
Rajesh, sorry to interrupt you. This is interesting background, but my question was about joining the movement for Immunization Agenda 2030. This session is experience sharing in the context of the movement for IA2030. So I just want to make sure.
So, yeah. Okay, I recently joined this movement last week. I mean, just last week only.
Yes, okay. So first of all, a warm welcome to you as a new member of the movement. Have you developed your action plan for IA2030?
Currently, I have shared my experience only. I mean, I have not, this experience sharing things I have done. So yet to do, I mean, the action plan, I have to develop the action plan.
Okay, wonderful, good to know. So I'm going to paste the links that you need to submit your action plan, and you want to do this preferably this week, because on the 23rd, we will be starting the Impact Accelerator. So with respect to your ongoing project, all you need to do is pick a specific objective, something you want to accomplish, that is in relation to the challenge that you face with these mobile populations, or it could be another challenge, and then define three corrective actions, and make the commitment to work on these corrective actions during the Impact Accelerator that will start on Monday. So we're now going to go, I hope that is clear. If you look in the chat, you will find the links, hopefully, to explain what is happening next in the movement, but a warm welcome to you. And there are over 2,000 people who have expressed their intent, as you have in the last few weeks, to join the movement. Most of them are on the Anglophone side. So let's go see Ndaeyo Iwot. You've heard, I hope you hear from the beginning of Rajesh Gupta's presentation about his ongoing work to reach mobile populations. So let's hear from you. Ndaeyo, you are a leader in the movement for IA2030. Please tell us, remind us who you are, and then what are your comments, questions, reflections? What experience would you like to share with Rajesh Gupta to help him with his ongoing work and with his Immunization Agenda 2030 challenge?
Thank you so much, Reda, for corporate coordination. Yes, I'm Dr. Iwot in Ndaeyo, Abuja, Nigeria. I operate at the sub-national level as a planner, coordinator, implementer, and evaluator of the Immunization and Primary Healthcare Scheme implementation in the Federal Capital Territory of Nigeria. I've been on this for over 30 years, and right now I'm retired into private practice, joining the civil societies, NGOs with a foundation, Community Care Foundation. And but I'm still linking up with government as a consultant to expand access to immunization in the Federal Capital Territory in particular, and the country at large. Yes, I'm one of the pioneer scholars on the IA2030, and in fact, I'm passionate about this, and I want to encourage everybody here to key into this. It's a global movement based on evidence and ideas with global thinking, but operations locally. So coming from that, I've submitted my action plan. That was a couple of days back, and essentially I'm working on human resource to improve access, physical access to immunization and PHC services. Of course, with my experience, I've heard about these children in some of the work action plans presented here, zero dose children, reaching them, a lot of stuff. And I want to particularly contribute to the missed children in the nomadic population, that we have got to segment the nomadic population, and we know them, some of them, they don't have temporary residence, they just move across in seasons, and some of them have where they reside when they migrate from areas that the pastures are drying up to areas that are green. So after some months, they will move to another place. In that situation, micro plan update is very important, and having a focal point embedded in them, that is one of them, should be made a focal point and participate in the planning, because when they are moving in season, they go to somewhere else. They have to link up with the, so planning for mobile population is not just a localized thing. It's a statewide or a nationwide programming that these populations have to be fully engaged, so that wherever they go to, they could be linked to services. By so doing, even the zero dose would also be issues would also be addressed. And whether I want to say that at this point, we have got to look at human resource as on the demand, on the supply side, because even when you have gotten a good plan, particularly during supplementary activities, national activities, where you have to recruit volunteers, when the supplementary activity is gone and you are back to routine, the weakness of the system in terms of human resource supply is very, very embarrassing. That is why I had to pick on that, because if we can improve on routine manpower to give the supply, the availability of the services, then we will begin to expand access. So my own situation, I'm leveraging on statutory funding mechanism from government. The National Health Act provides 1% of the basic incubation fund as a consolidated revenue for the country to be plowed into the primary healthcare subsector, and 5% of what is given to the state for program is meant for human resource, and that would be for midwives and community health extension workers. So going by the guidelines, this funding is sustainable. It's only predicated on the availability of the revenue agreed to the government. So where the revenue has improved, there you improve, you expect improve 1% allocation. Where it has decreased, then you expect. So this is where the issues are, the threats could come to this source of funding. And on routine activities, we have challenges that partners, WHO, UNICEF, and other donor agencies, they don't support payment of salaries to routine to permanent staff or volunteers. They prefer, paying for logistics and demand side activities and other inputs. You see, so government takes responsibility for human resource, and with the dwindling government resources, human resource is still an issue. So I'm addressing this issue in a situation that a location that we have 30% attainment of minimum supply of human resource, and this is impacting on the medical services and care systems.
Thank you, Iwot. Yeah. I'm going to go to ask Rajesh Gupta. And Ndaeyo, Iwot, you shared your experience and your concern with human resources issues. So Rajesh Gupta, you opened this experience sharing with your presentation, reporting on the work you've been doing to reach the unreached in mobile population. Rajesh, can you tell us if if what Ndaeyo has shared is useful to you, and if so, how is it useful? And then we will go to François Gasse for follow-up questions about your presentation. Rajesh, are you able to unmute, please?
So definitely, sir, the activity was very useful. As I shared in my presentation, that the children which we vaccinated during this activity was...
No, Rajesh, I'm sorry, you're misunderstanding. I'm not asking you if what you did was useful to you. I'm asking you if what Ndaeyo Iwot, a colleague from the movement for IA2030, he just shared his experience. Is this experience useful to you in taking your project forward, in preparing your IA2030 action plan, which is your next task now that you have joined the movement?
Right. So definitely, sir, it will be useful for me, the experience shared by sir. So I will definitely incorporate some of the activities, some of the experience in my also.
Okay, thank you, Rajesh. Now, François, what are your questions for Rajesh? We heard a very interesting presentation with clearly documented data about children including children who'd never been previously vaccinated and who were vaccinated through this outreach effort. What are your questions or comments or initial thoughts for Rajesh Gupta?
My initial thought is that there are hard to reach and left out children, I think, in every cities, to a large or small extent. And I think Rachet has put in place a strategy that may not reach 100% of the left out, but reach a number, and every child counts, and 600 is not a small figure. And I think he shares the challenge of this approach that he put in place with results and things which are still unknown and new challenge that he need to address. My first question to him is that those 600, he talks about 3 districts. How, the 3 districts, what is their coverage? What percentage represent the never reached children, or is it unknown? It was only discovered during the polio SIAs and reported with a sort of a location. What's his target? Has he got any idea of a target? What is the coverage for the Penta-1 in the cities, the district cities that he mentioned? That's my first question.
So the coverage if I say quota, there are 3 districts, but this activity is related to the quota districts.
Yes.
So the coverage is around 85 to 87% as per, the parents and child tracking system, PCTS, the software we are having. So we are having that the 85 to 87% in last 3 to 4 years. If I say about the survey data, the recent survey data, as per the survey data also, we are finding the full immunization is around 85% for the districts.
And the 15% not immunized represent what number, absolute number? I don't know the size, more or less.
15%. So if I say the target is around 40,000, right? So out of this 40,000, if I say around 10%, so I can say 15% is around going to be 6,000, which are under vaccinated.
There's 6,000, and so this mobile population represent about 10% of the unvaccinated that you have reached.
So this is definitely this is something, the area which is not, I mean, we are covering, but we are not getting any advantage, right?
Okay.
So we are trying to cover up the under vaccinated. There are other areas also where we are working, but this chunk of children was not getting benefited by our other activities.
And this is very useful. I'm trying to see the context in which you try to reach these children. My second question is that if I understood well, the identification of those kids are coming from polio household visit, and then the listing, or do you have any complementary strategy? That's my second question. My third would be, are you going to keep the site at the same site for the identify? Because those people move from home to home, do they stay always the same area of the city during the famous holiday time? Or do they move around the city in different parts of the city according to the project? Is it a keep moving population?
So they move, definitely. They are staying at one place for one project, and at the same time they might go back to their state or districts. The other population may come. So it depends. They can move within the city from one project to another project, or sometimes the new people will be coming to the new project. So it may be I mean, either scenario. I mean, you will be finding, I mean, the newer places. So I told you, I mean, every 6 monthly you have to update your, I mean, such areas, such sites where you can plan your sessions for this vaccination program. So we have to keep on updating. Yeah.
So a big challenge, as you are mentioning, is tracking the dose needed by those kids over time and sustaining your achievement.
Yes, definitely. That is, I mean, one of the bigger challenge, and definitely, I mean, the peri-urban areas, which is developing areas. I mean, the newer projects are coming up. So definitely these are the areas. So currently, I mean, definitely there is a urban area strengthening program is going also. We are having some additional manpower also, which can, I mean, go to these areas and they can enlist these areas, and definitely we can provide the services in these areas.
Okay, thank you. I think it's a very interesting experience. Of course, it's getting those kids left out is a step-by-step project, and then you learn as you do and as you go, but you already showed some results. And of course, there's some more challenge you have listed that to do better, each of those challenges should be addressed. And I was pleased to see that you mobilize human resources and once a month. So I think you have made an innovation that can be useful for other people in the movement. Thank you very much for your commitment and dedication for that.
Thank you very much, sir. Thank you very much.
Thank you, François. Thank you, Rajesh Gupta. I'm looking for comments that are specifically sharing experience. I do note the question because we have a hard stop. We're closing in 1 minute. So Syed Meraban Shah Syed Zai says, what is the underlying reasons for these people in the who are in movement? So the mobile population. And then we have, and that was the same root cause question that was asked earlier by Melissa Teferi. And then we have Mohammed Nasir Umar. What plan do you have to improve the default tracking system? And a question from, okay, so I want to acknowledge and thank Ugo Jovita Ebere, who says, well done, Dr. Iwot, in response to the experience shared by Dr. Iwot. And then Samuel Johnson, who says, microplan and the focal person for the migrants population that shall be a link between immunization officials to track movement is KEEP. I'm not sure. So I think, yeah, Samuel, I wish we had more time to hear from you. And then Mohammed Nasir Umar says, Rajesh can also consider the community engagement strategy to support this. All right. This feels like we're cutting short. A fascinating discussion. Again, thank you, Rajesh Gupta, for having prepared a presentation. We usually do a pure oral presentation. It was interesting to see slides with specific data that we could, latch onto in this discussion. Want to thank all of you for participating in the experience sharing. As you know, we'll be meeting again on Thursday, and I've posted in the chat, I will post it one last time, the instructions to stay in the movement for Immunization Agenda 2030. I'm asking you all to unmute so we can say goodbye to each other.
Bye.
Goodbye.
Thank you for sharing.
Goodbye.
Thank you for
See
the
you next time.
Goodbye. Thank you for this educative
Bye.
moments. Yeah,
Bye.
bye-bye.
Thanks, Reda.
Bye.
Thank you.
Thank you. God bless you.
Thank you. See you on Thursday.
Unfortunately, we couldn't join early. Oh,
Bye.
I'm going to ask you, as I
due
usually
to
do,
poor connectivity, we
to,
couldn't join early, rather.
if you can go to the link I just posted and share with colleagues what you learned from experience sharing. And this is not to boast, but simply to share with them what you learned. So even those who are absent will still benefit. That again. And goodbye.
Okay, thank you so much. My name is Margaret Odera. I'm a community health worker, Mathare North Health Center, Nairobi, Kenya. I am new here, and I was very, very happy for this educative session. Thank you so much. See you on Thursday.
Thank you, Margaret. Take care, all of you, and look forward to seeing you on Thursday for those of you who are able to come. And everyone, Monday at the assembly will be launching the Impact Accelerator. So probably the most important part of the movement, because it's going to focus on implementation. Take care.
Okay, this has been very, very educative for me. I was listening to everything. I'm so new here, and I'm ready to learn. And I hope to give my presentation on Thursday. Yes, as a community health worker, I know it will be, I'm so much interested in this, and I will tell my friends. Yes.
Thank you, Margaret. This is how we build a movement together. You're now part of a movement. Welcome to the family, to all of you who are new and who have just joined us. And let's keep growing this movement together. See you Thursday and then Monday to launch the Impact Accelerator. Take care.
Okay, Reda. Thank you so much. Bye.
Take care.
All right.
And don't forget to tell your colleagues what they missed by going to the channel.